Welcome everyone to this webinar, which is part of our series on ethics and COVID-19. My name is Paul Ndebele. I'm with the Office of Research Excellence in the School of Public Health here at the George Washington University. I'm also with the Department of Global Health, where I teach various ethics courses. And welcome to this, our 26th webinar. And these webinars are hosted by the Bioethics Interest Group here at the George Washington University, and also with in collaboration with the Office of Research Excellence, and also in partnership with our R25 grant in Mali, which is looking into promoting research ethics in Mali, and also with our G11 grant in Kinshasa at the Kinshasa School of Public Health. Today we're going to focus on a topic which is particularly relevant if we consider the situation we are facing right now as the world. We are going to focus on the topic of global vaccine equity, and if we consider the new variant that has just been identified, it actually means we have to think importantly about issues of global vaccine equity. So today we've got two panelists who are doing lots of interesting work in this area. And as they will be giving their talks, I would like to encourage all of you to submit your questions and comments using the chat function. So after they are done with their talks, we'll then go through those questions and comments. And to get us moving, I'm going to introduce our first speaker, who is Dr. Louise Ivers, who is the Executive Director of the Massachusetts General Hospital Center for Global Health. She is an Associate Professor of Global Health and Social Medicine, and also an Associate Professor of Medicine at Harvard Medical School. She's also a Special Advisor for Partners in Health, an international non-profit organization that provides direct healthcare and social services to the vulnerable communities around the world. So over to you, Louise, so that you can share with us your views on this very, very important topic.
Great, thank you so much for inviting me. I'll share my screen here, and maybe you can just give me a thumbs up that you can see that, or a nod, or yes, great. So really appreciate the opportunity to talk about this topic. Actually, as I was speaking with the other panelists just before we started, I mentioned that at 1 p.m. today on the steps of Massachusetts General Hospital, we are having a meeting of solidarity, a vigil, a protest of some degree to talk about vaccine equity, trying to amplify voices of our colleagues who are really eager to have vaccines for themselves, for their family members, for their patients, for healthcare workers. So it's really great to be speaking with you directly before that. I just have a couple of slides to kind of frame the conversation. I'll touch on a couple of things very lightly and can't wait for the conversation. I do want to highlight that discovery and delivery of biomedical interventions, biomedical inventions have never just trickled down when we talk about infectious diseases or non-communicable diseases around the world. And we could take examples about the HIV pandemic, tuberculosis pandemic, cholera pandemics, and now COVID-19. In many ways, history has taught us that this will never happen just by chance. It only happens by choice. Health systems around the world often don't have the capacity to provide care for even moderately ill patients. And we see a lot of heterogeneity when I talk about around the world. I do also mean in rural parts of North America, as well as in low and middle income countries. It's not just a binary conversation about the US and Europe and other places. The health workforce around the world really has major gaps. In some places, this is just a distribution of healthcare workers. In other, it's a true lack of numbers of healthcare workers, but we have major systemic problems there. Access to diagnostics, therapeutics, and preventative care for many diseases that are responsible for global deaths have never been made available to the people who need them the most. And the social determinants of health, which are so inequitably distributed among groups, have also not adequately been addressed. If we look at this public health crisis about global inequity related to COVID-19 vaccines, we can see that even though in some places, especially here in Massachusetts, we've been feeling relatively, as though we're doing relatively well with COVID-19 in terms of hospitalizations and serious morbidity, globally, the number of deaths happening every day is more now than it was a year ago before we really even had vaccines or knew as much as we know about COVID-19. Very concerning. The WHO has estimated that there will be over 5 million preventable deaths by 2026 of COVID-19 and about 5 trillion global US dollars of economic loss. And that economic loss is not equally distributed around the world either, because advanced economies are projected to recover far more quickly than other economies will. Here, again, projections lumping a whole subcontinent together, but still the point is that the impact of this will not be equitably seen. And the panel today is really to talk about vaccines, but I do want to highlight that health systems are needed to deliver preventative and curative care. And if you look at the numbers around COVID-19 testing, COVID-19 treatments, some of those are emerging oral therapeutics, but also just as simple as medical oxygen and personal protective equipment that healthcare workers need to be able to safely take care of patients are not equally available or equitably available. And we really should also be cautious about separating what are really interlocking issues that need to be addressed, which is about health systems. But to focus on vaccines, any way that you look at these numbers, it is absolutely atrocious and a moral catastrophe that I think many of us have signaled and talked about and called for addressing for a very, very long time. But unfortunately, a picture tells 1,000 words, and you can see how very, very few percentage of people on the African continent in particular have been fully vaccinated. And this is largely driven by a lack of supply of vaccine. I show this another way of looking at vaccinations, fully vaccinated around the world, to highlight that it is important to point out that many low and middle income countries have very capable systems of delivering vaccinations. If you look at India, where there was a very large surge in the middle of 2021 of cases, there was a rapid increase in production of vaccines in India and very capable delivery systems with community health workers. If you look at middle income countries like Chile, if you look at Cuba, vaccines can get delivered. This continues to be a supply issue for vaccines. I want to touch on testing disparities because you can't actually treat COVID or even properly prevent and contain it if you can't test for it. We've seen this fantastic identification of a new variant of concern in Botswana and South Africa, but a lack of access to genomic sequencing tools is really important all around the world and a challenge for surveillance. What you look at is see an over-centralization of testing in low-income countries on average. At the end of September 2021, there were 13 daily tests per 100,000 population, and that compared to 740 tests per 100,000 population. If we don't look for SARS-CoV-2, we're not going to find it. And if we don't do adequate surveillance, we're going to continue to be in the challenge of trying to escape or react to the variants that emerge. This is a photograph from early this morning. My colleagues in Imbarara, Southwest Uganda, where we have worked for more than 10 years. And today at 1 o'clock, we'll go and do our standing in solidarity with them. Our colleagues want vaccination. They want their healthcare worker colleagues to be vaccinated. The question about hesitancy around vaccines is being over amplified because the issue right now is really about supply, and I'll keep going on about that. If you're interested and are not familiar with the Africa CDC website, is fantastic and has wonderful data there to look at. For every country that's part of the Africa CDC, they have a metric where you can see that for Uganda, for example, they have administered, as of 2 weeks ago, 71% of the supply that they have. And this is still only getting them access to 6% of their population. So the issue of vaccine supply continues to be the biggest challenge for our colleagues in delivering COVID-19 vaccine. The consequences of this are fairly obvious to me, and to many, and maybe to all of you, but it does seem like we have a challenge in getting that message to the people who are making the decisions. There are serious public health consequences. There's morbidity from COVID-19. There's mortality from COVID-19. COVID-19, like all pandemics, crowd out the health system. And we saw even in the US, a huge reduction in the number of people seeking non-COVID-19 care, especially among the people who actually need it the most. Pandemics have gendered impacts that are long lasting. And even more now, we see in the news the concern about variants and endemicity of COVID-19. This is just one of the potential impacts. And of course, the variants of concern do come back around to potentially threaten those who've already been vaccinated, which if nothing else should be an issue. But for me, this is also a major moral challenge and a moral problem. How do we want future generations to look at our actions when we've allowed private interests and a self-centeredness to really dominate our response to this pandemic? I think it's really a tragedy. The White House in the US has really been on the fences, having stated they're supportive of a transfer of intellectual property, but in October saying they weren't really sure how to do it. More recently this weekend, President Biden being a little more deliberate in saying that he wants to ensure there's a waiver of intellectual property. But what I think is really, really clear here as it relates to vaccines is that there has been a total market failure. The vaccines, the pharmaceuticals, the diagnostics, and public funding was heavily invested in the development of these tools. We should ask ourselves whether we're going to keep talking about these unprecedented times. Are they truly unprecedented? And are we going to take the unprecedented action that's needed? Or are we going to end up in the same old story that we always have, which is where the wealthiest people in the world have access to the tools of modern science and the poorest people in the world actually don't? We really have an urgent need to increase vaccine production capacity now. And there are many ways to do this: through a TRIPS waiver at the World Trade Organization, technology transfer, the US use of the Defense Production Act, donation of doses, and supporting health systems. And I look forward to the conversation that we'll have today, and I'll pass it back to the chair or to my colleague, Emily, for her comments. Thanks.
Thank you very much, Louise, for taking us through this very, very interesting, was it 10 minutes or so, full of ideas. You mentioned issues about discoveries that do not trickle down, particularly when we're focusing on the poor countries. You have also reminded us that when we're looking at global inequity, we need to continue reminding ourselves that we also have to continue talking about tests, about emerging treatments, and also even about PPE, in addition to vaccines. You also importantly also reminded us that nobody is safe until everybody is safe. That's a very, very important message. And he also reminded us that in so many parts of the world, it's not about vaccine hesitancy because they don't have the supplies, right? So the issue actually is that they don't have the vaccines that they can use. So when you're talking about vaccine hesitancy, that's actually a luxury because you actually have the vaccines and you choose not to go for the vaccines. But he also touched on the very, very important fact that our response as a world has been dominated by private interests, and more importantly, focusing on the very, very effective vaccines that we have right now, which is Pfizer and Moderna, and all these issues about the patents and so forth. But more importantly, he also suggested various alternatives in terms of how we can improve on vaccine equity globally. So thank you very much for all those great ideas. So now we'll move on to our second speaker, who is our own Emily Smith. So Emily Smith is an assistant professor in the Department of Global Health. So I also belong to the Department of Global Health. She is also affiliated with the Department of Exercise and Nutrition Sciences. And Emily is doing lots of interesting research that is focusing on improving maternal, newborn, child, and adolescent health in low and middle income countries. But more importantly, when it comes to these issues, Emily is an advocate, just like Louise is an advocate too. And from here, Louise is actually marching outside in solidarity with the other countries. So over to Emily so that you can share with us your views on this very, very important topic.
Thank you, Paul, and thanks for having me. As you said, I'm an epidemiologist, but happy to share a few of the data points that I find motivating here and a few of my thoughts about how we can advocate for global vaccine equity. So the question of what is equity is always an interesting and interesting question. But for me, I think about getting the vaccine to the right people at the right time at the right price. And we hear call after call, and we know we have the tools to bring the pandemic under control, but it's a question of sharing them fairly. And WHO early this year laid out a global strategy to vaccinate 40% of the population of every country by the end of this year and 70% by mid-2022, really focusing on prioritizing older people and health workers and others at risk. But we're coming to the end of 2021, and where are we? Today's data from our World in Data, which the maps that Dr. Ivers showed were great, show that only 5.9% of people in low-income countries have received at least a single dose, which is pretty shocking inequity. And one of the things that I thought it was important to show is here is you actually see the timeline since December last year until today. By continent, the share of people who are fully vaccinated or partially vaccinated against COVID-19. And what you see is that global vaccine equity gaps started from the very beginning, and they continue to worsen today. In particular, you'll see by the end, by the time we get today, that share of people living in Africa who are fully vaccinated is still 7% of the population. And that has, really not improved over the course of the year. It's quite shocking. And when we dig into the data, of course, Africa, many 49 countries in sub-Saharan Africa, you're looking at here, about half of countries have fewer than 1 in 10 people have gotten a vaccine. And then in a handful of countries, Niger, Burkina Faso, South Sudan, DRC, fewer than 1 in 50 people have gotten a vaccine. So these are pretty catastrophic numbers. And, we all, I think, have agreed that healthcare workers should feature prominently in any prioritization scheme. And a report from WHO African region found that just 1 in 4 healthcare workers have been fully vaccinated. And so that's falling really short of the WHO targets. And I think falling short of shared global values to prioritize high risk people. The other thing that I think is important to note here, I'm sharing some early data from a second round of surveys. So I've been working with colleagues at Harvard School of Public Health, Africa CDC, and about a dozen universities across sub-Saharan Africa to do a series of surveys around COVID-19. And the most recent set of surveys that went through July through October of this year, we asked many questions about the vaccines. And so here you're just looking at some of the data from my colleagues at Kintampo Health Research Center. And here we asked, when do you think a COVID-19 vaccine will be made available to you? And mind you, this is in Ghana, the first country to receive any vaccines in sub-Saharan Africa via COVAX. And in July, so well after the first doses had arrived, 70% of people say they don't know when a vaccine will be made available to you. And then about 1 in 5 are still saying they think never or beyond 2023. And so to me, this was actually the most alarming part of the whole survey. And we have, in a few weeks, we'll have more data from other countries and from healthcare workers in particular. But I think this is really alarming. So when we talk about readiness, vaccine readiness or hesitancy, I think we can't underestimate really the feeling that for many people that they'll never actually have access or they don't know when they'll have access. And the other little bit of data I wanted to share is this is data from a rapid review that some of my team did in collaboration with Abdullah Noor from UNICEF Tanzania, where we wanted to look at gender equity in vaccine distribution. And what we found, we did a review of 49 countries in sub-Saharan Africa looking at national platforms or reports for their vaccine distribution, and only 5 countries had any data that was disaggregated by sex. And what you can see here is that 4 of those 5 countries, women were less likely to get vaccinated. And that's pretty surprising because, of course, women make up 80+% of the global healthcare workforce. And so anyway, so of course I do a lot of work on women's health and maternal health. And so I think it's another point to really bring to the forefront, even as we're talking about global vaccine inequity, as Dr. Ivers pointed out, there is important also to consider national inequity. All right, so why do we have inequity? 2 big points that are brought up. One is the private sector continues to prioritize deliveries to wealthy countries and restrict the global supply. So here's some data from an Amnesty International report in September 2021. First, the Pfizer had delivered 9 times more vaccine to Sweden than all low-income countries combined. Moderna at that point had not given a single vaccine dose to a single low-income country. And AstraZeneca had also refused a number of these tech transfer initiatives. And the other big thing happening right now is that wealthy countries are continuing to stockpile COVID-19 vaccines, which I think is, locally, people are worried about booster shots, but what you see here is that dark blue color is booster shots. And along the x-axis, you're looking at over time. So this is a projection into June 2022. And what you actually see are in red donation targets, which are great. We also see excess stockpile happening here. And so an expected 1 billion excess doses that are slated to be unused are expected to be stockpiled in wealthy countries by middle of next year. So what to do? I think there's a nice piece that came out over Thanksgiving from Madhu Pai at McGill about 10 reasons why everyone should advocate for vaccine equity. I think preaching to the choir here, I'm very sure of it. But it's the moral thing to do. We believe health is a human right, but it's also the smart thing to do. And I think that, we have a special moment now because that really see a lot of headlines of a kind of I told you so variety. And so I do think we have a moment now to really highlight the importance of this idea that the pandemic won't be over until everyone has access to vaccines and therapeutics. And then I just wanted to highlight a few specific advocacy campaigns. So WHO does have an ongoing campaign with clear targets and a specific request for contracts and delivery via COVAX and via the Africa African Vaccine Acquisition Trust, or AVAT. And so those are very clear asks from WHO to other governments and to private sector companies. And you'll also see here on the right, I've worked a bit with MSF, or Doctors Without Borders, who has a specific campaign 2 weeks ago. Here you can see us at the White House delivering a petition to the Biden administration with 3 asks. One about donating more vaccines. So the Biden administration will say, we're donating a lot of vaccines. It's true, more are needed. And the second is to adopt the TRIPS waiver, which everyone is calling for. And that's not just on the vaccines, but all medical tools, as Dr. Ivers pointed out. And then thirdly is to support scale up and capacity for mRNA vaccine manufacturing, which is an interesting point. The other interesting advocacy piece I thought that Peter Singer raised last week is that there are clear asks to companies, to pharmaceutical companies. And so I think that's another place where advocacy can happen. If you or anyone you know are investors or board members, the issue is prioritizing vaccine delivery. Of course, the contracts are there, but the delivery is not happening. So via COVAX or AVAT. And then the second is to support tech transfer. And there are a number of the Tech Transfer Hub and CTAP. These are set up mechanisms where this technology and IP transfer can happen. And so I think that's another avenue for advocacy. And then, lastly, I guess my personal thoughts are that we need to be an advocate for vaccine equity. As a researcher, global health research, I always think of the research itself as sometimes as a form of advocacy, but I think, it's not working. So really now is the time to take action. And we do, as Paul have pointed out, have probably a special moment now with, do or undo panic happening over the Omicron variant. I think we do have a special moment now to really make inroads through advocacy. So my 10 cents on why we should advocate and how we can do that. So back to you. Thanks, Paul.
Thank you very much, Emily, and particularly thank you for ending up with that call for all of us to advocate for vaccine equity. You started off by actually emphasizing that vaccine equity is about getting vaccines to the right places at the right time, and we might actually ask, when is the right time? The right time was yesterday, right? But right now is also the right time, so that to make sure we're addressing these issues. You painted a gloomy picture of what's happening, particularly focusing on the African continent, where you are doing lots of your research, and stating that 7% of Africa, less than 7% has actually been vaccinated. And try and compare that to the US, and try and compare that to the Western Europe, you then realize there are some stark differences. He also painted a gloomy picture when it comes to the health workers in Africa. They are most exposed because of the working conditions, and yet a greater majority of them have not yet been fully vaccinated. And he also even highlighted the fact that for now, here in the US, we are now talking about the booster shots, right? And we're forgetting about the basics of ensuring that others elsewhere actually have access to the 2 shots, right? That we've always been talking about. And then you gave 10 reasons why everyone should advocate for vaccine equity. Later on, I'm going to go through that slide again so that I can always be talking about that, all those various reasons. So there are lots of questions that are coming in through the chat function. And I'm going to direct the first question to Louise. A lot of the research is actually funded using the public dollars. So the question here is, how can future public investments be made contingent on sharing vaccines or medicines developed from them?
Yeah, that's a great question. I don't personally have the exact answer to that. I think that, I don't know if we have lawyers in the group or attorneys. It seems to me absurd that the US government in particular, where I have more familiarity with the public funding mechanisms, hadn't put contingencies on here. I don't really understand it. Even in our academic places, when there's intellectual property created, there's already agreements over who owns what, and part goes to the lab and part goes to the institution. So to me, it's just astounding. I never would have realized that that kind of arrangement would be made. I think we've seen similar scenarios though, right? If we look at HIV prevention and the use of tenofovir and accessibility to that, in some ways I'm telling myself I shouldn't keep being surprised. So I don't know exactly the answer, but it seems to me it should be a fundamental part of large public investments like that to ensure that there's access and equity, whether it's in the US or in Europe or other places that received public funding. Maybe others have more specific insights into that.
Thanks. Emily, any thoughts?
The only thing I'll add is I work mostly with the Gates Foundation, which is an interesting story here with AstraZeneca, but it is an example where there are parts of the grant agreement that require global access. And what global access means is a second discussion, but I think there are clear models for how that can be built into contracts for grants. And so, especially for US folks, I think it's an important consideration that we need to reconsider those clauses, particularly in federal funding. So that's the only little bit of insight I have.
Thank you. There is another question here that is focusing on the local COVID-19 epidemiology. So the question goes, some might argue that current distribution of vaccines is less inequitable than it might seem, given the disproportionate number of COVID-19 cases and deaths in many high-income countries. How should we think about the relationship between vaccine equity and local COVID-19 epidemiology? Emily.
Yes, this is a great question, and I guess I think we should think about those, or traditionally we think about those, because of course, how I think about equity is having the right medical products in the right place at the right time, and the right time refers to local epidemiology. So there's no question that we can make a case for considering that inequity. So that's a big picture comment. However, there are other components to equity, like people at high risk, right? So healthcare workers, I think, is a very good example. Like, there's no reason to have 1 in 4 healthcare workers vaccinated across sub-Saharan Africa. So yes, I think there's a place for considering the local epidemic, but that doesn't account for the inequity we see as one. And then a second piece is, at some point there, it's almost like that argument is rewarding bad behavior. So there are a number of countries, particularly in Western Africa, with a lot of experience in epidemic response, that did a great job controlling the initial waves of the epidemic. So we will also have to consider that poor pandemic control on the part of governments in the West does not entitle them to not just a supply, but I think that one of the figures I showed you is a stockpiling of vaccines. So it's a yes, but.
Yeah, I'd love to chime in on that too. I think it's really important to kind of unpack that question, because it's a good one. And I do think, because one of the questions is, like, the issues have been raised so many times, why are we not getting such a response? I do hear back often people saying, oh, but they're not really having too much COVID in, say, Haiti, where I work, or in Uganda. But in actual fact, like, it's important to look at in many countries, even when there's a lower total number of COVID-19 cases reported, the case fatality ratio has been quite high. So in Haiti, for example, where there's a total lower number of reported cases, although testing is very hard to come by and really under-tested. However, there's a 3% case fatality ratio. Yemen reported a 19% case fatality ratio. Niger was 3.7%. So we're seeing still relatively high mortality amongst tested and diagnosed cases. We know obviously there's a huge heterogeneity in the global data systems, so we suspect there's under-testing. But when you look at that, you have to be careful about presuming that actually the vaccine is not necessary. We also then see how the emergence of local variants is very important, whether we have one of global concern or just local concern. And then when you add to that the fact that the vulnerable populations, as Emily mentioned, whether it's healthcare workers who deserve to be protected just as much as any other healthcare worker, I think we have to push away. So it's possible we don't need 100% vaccination, or it's 85% vaccination in some communities. That's certainly epidemiologically possible. But do we need more than 6% of populations vaccinated? Absolutely yes. And is the biggest problem they have the supply? Absolutely yes. So I think that's where we have to get to into the discussion there.
Right. Another question actually has to do with the joint statement on dose donations of COVID-19 vaccines. So there is one participant who is asking you both to comment on the joint statement on dose donations, which brings into focus some of the logistical realities that confound vaccine equity.
Yeah, I'm happy to start with that one. I think it's really important to read that, and I have read that, which highlighting a lot of the structural challenges that I think come with a charity approach to global health in general. If our approach to global health equity is that we give a little bit of our leftovers in donations, I mean, I'm being a bit extreme there in that, but this is not going to solve the problem from a structural perspective. So some of the challenges of donations have been that they are inconsistent in timing, that they're not predictable, that there are a variety of different types of vaccines. So you have some countries that are trying to manage mass campaigns with 3 different or 4 different vaccines with different logistics requirements. So these are some of the structural things that I think are why, for example, I will always be advocating not for charity, but for rights-based health systems supported approaches to any global health challenge. I think that's another, in addition to the questions about the epidemiology of COVID-19, we'll often hear folks say, but look, we're donating, we've made commitments of many, many millions or billions of donated vaccines, which is nice, but it's still it's not enough. And I think that document does get at helping to understand why that's not enough.
Thank you. And Emily, any thoughts?
Yes, I'll just add that one, this issue around transparency, around delivery schedules, as I understand from colleagues, is a major issue in planning things. And if we reflect back to domestic issues, you may remember that the Biden administration actually decided not to initiate some of the communication strategies before the vaccine was widely available, out of kind of fear that demand would ramp up too high before they were able to deliver. And you'll also think that no one required us in the US to have a strategy to reach our entire population before we were able to procure doses. And anyways, I think for some of these questions, I also like to think of the kind of double standard that we apply towards having access to these products that are essential medicines. And so some of those comparisons, I think, are really helpful in thinking about how we think about government readiness to deliver. I mean, of course, it's important for health systems to deliver, and I think we can probably have our health system colleagues have comments for all countries and their vaccine delivery strategy.
Thank you. And when we look at issues around equity, issues of IP come to the front, right? It's about money, it's about who owns the intellectual property. So right now we are looking at two of the most effective vaccines, which is Pfizer, which is Moderna, and yet there are IP issues there. And Gerald has actually provided us with an explanation with regards to the US regulations that relate to issues around intellectual property. And there is another interesting question from one of the participants, which reads, if the patents were waived tomorrow, do low and middle income countries have the capacity to produce the quantity needed of these vaccines? We can start off with Louise.
Well, I think it's a good, I'm sure you do this in your global health department and public health school, like we try to, we use the term LMICs and the global north and global south, but obviously it is not binary. There is not a binary breakdown here. And so some LMICs are global producers of vaccines. If you look at India, it's producing normally a large proportion of the world's vaccines. And yet the continent of Africa does not produce its own vaccines, although the director of African CDC has said that this is now clearly a mission that needs to be changed, not just for this pandemic, but also for the future. So I think some countries do not have the capacity to do this right now, but that is why almost all of us who are advocating for increased production of vaccine are talking not just about intellectual property waiver, but also the transfer of trade secrets, because those are critical as well to manufacturing. You can't just kind of get the IP and then make it. There are many trade secrets and human resources expertise that are needed. And there needs to be manufacturing capacity that's actually created in order to respond to this. So there's a lot of work to do. I don't think any of us here advocating would pretend that it's simple, and intellectual property is just one component of it. We need all of the components. And this is why I also will often refer back to the notion of health systems. We need to build health systems through this crisis that will be there for the future as well, because this is unlikely to be the only pandemic. It's not even the only one that we're currently trying to address in the world. So we need to invest in the other things that the countries need and have regional centers where this is possible on every continent.
Yeah, so you're actually looking also at issues of leadership on the part of those low and middle income countries to show that we are in this together. Emily, any thoughts?
Yeah, I'll add, I just put in the chat there, I had this exact question, Heather, and I, of course, know nothing about manufacturing drugs. So, but I did find this piece of investigative journalism very compelling on this particular issue, which is an investigation of 10 pharmaceutical companies in Brazil, Argentina, South Africa, India, and Indonesia, which does find, I thought it was just a really thorough investigation of this claim. And really, this piece concludes that the capacity is there, in particular for mRNA vaccines, which, as I understand, maybe are more closely or more similar to production of therapeutics rather than traditional vaccines. So I think capacity is there. At least this, for me, refutes this argument that no one could do it. There are a number of companies, and as Louise points out as well. And I think the second piece here is timeline. If we sign the TRIPS waiver today or transfer IP today, will a vaccine appear in DRC tomorrow? No, absolutely not. There's, of course, a time lag to get this up and running and to get production up. But it's very clear that we're not going to solve this tomorrow either way, that the timeline we're on now is a long timeline to vaccinate the world. We're not going to finish it in 2021. I'm not sure we're going to finish it in 2022. And so I do think it needs to be part of the solution because we're not moving fast enough. And exactly as I see in the chat, 2-year window, best case from David. And so there is time for this to make a difference. And besides that, it's time to invest in global capacity. We don't want to be in this situation again. And I think as we've seen very clearly in the way that particularly Moderna has prioritized delivery of different contracts, that where the IP lives, where the vaccine is produced, does matter in which contracts are delivered on first. And so anyways, for all of these reasons, I do think that is an important part of kind of these three different things that we should do. Yes, donate now. Yes, sign TRIPS waiver. Yes, invest in this manufacturing capacity globally.
Thank you. And there is this interesting question that might actually force us to think about the issues around vaccine equity in a kind of fresh way. And for example, if we're looking at the new variants that are coming in, and then when we're talking about vaccine equity, are we actually talking about a moving target? So the question is, are we actually entering into a period with these later variants such that those donations that are made involving the older COVID vaccines will begin to become less relevant, right? So that with every new variants that are coming in, we might actually need some new vaccines. So even if we talk about donations of the older, the vaccines that were meant for the older, variants would actually be less relevant. Any thoughts, Louise?
I mean, it's certainly something that we need to keep our eye on. We don't know yet, obviously, with the newest variant, whether there's immune escape from the vaccines, but I do think the point is very well made. And, it's again, I don't mean to be flippant, but having worked in the global health space for a very long time, we sometimes say, in disaster response, don't send me your dirty old shoes. Like, I can't use them here. And I don't want us to get to this exact situation that the audience member has proposed, where the vaccines that nobody else wants or needs because they have better ones get shipped off. That would be pretty disastrous, but one could imagine that happening the way, if we continue on the same trajectory where we are really hoarding, over stockpiling far beyond our needs, to the detriment of the most vulnerable frontline workers, frontline providers, and all the people. I saw the White House was having a celebration here in the US yesterday, and the holiday scenario in the White House was frontline workers, in the post office and the grocery store, and all of those people all around the world still need vaccines too. So I can imagine this terrible scenario playing out. I hope it doesn't. And I think, as Emily pointed out, and I really liked her slide on let's all keep putting the pressure on. I think our voices are heard on these things. If we all speak up and speak out about different aspects of it, we can't let that scenario happen. It would be awful, but I could imagine that type of thing happening in the future if we stay the way we are.
Right. Emily?
I guess I'll just echo that this exact scenario that David proposes is another reason that charity can't be our first line of response to solving global issues. And so this, again, for me, argues in favor of investing in global production capacity. And I think it's just another good example. And, maybe we have, I do think we have a moment now where this issue is clear. And so hopefully this we're able to seize this and make some movement in this issue.
Thanks. And I want to come back to you, Emily, because of the statistic that you actually raised about 1 in 4 health workers in Africa who are not yet fully vaccinated. In your view, what's going wrong and what can be done to ensure that that weakness is addressed?
I've worked in Tanzania and Ghana the last 10 or 15 years. So this is where many of my colleagues are, and it's interesting. So like I said, in Ghana, the case was the government organized and the first to receive vaccines, but all of my colleagues, all healthcare workers, got one dose and didn't hear for months about when they could get their second dose. And so that was an example. I think really the country has suffered from unclear delivery schedule. And so it is really hard to make this, like, how do we have the right number of doses to get people their second dose, has been a major issue. And then in Tanzania, I think, of course, it's been a difficult political situation over the course of the pandemic, but really for a long time, we're talking about just a few thousand doses having been delivered to the country. And so we're talking about really low supply. And I think that's for many countries where the numbers are so low, when we're talking about 1 in 50 or 1 in 10 people being vaccinated. I think that supply is the number one issue. But I am interested in the question, and there's really just not enough data out there, that part of this may also, I think, be internally an equity issue, right? So we have healthcare workers who 80+% are females, who this may not be a prestigious job to be a community health worker or to be a nurse in a place. You're not a person necessarily with money or power. And so when we have really scarce resources, I think that there are a lot of other equity issues happening about who gets access. And so I think that is probably another thing happening that we don't know so much about. There are a lot of equity dynamics happening here.
Thank you. Now I am going to allow Louise to give your parting shots. In a minute, we want to release you early so that you can go and participate with others, outside.
Well, thank you so much for the opportunity to join you today and for the conversation. And it was great to meet you, Emily, and hear your perspectives. And I hope we might have the opportunity to amplify each other's voices, or maybe even work together on this. I do want to just address the final question in the chat about who do we put the pressure on. I do think that we have a challenge in understanding where in our global health security, global health delivery systems in US government, we can actually really find the allies we need to push forward on this. I think that wherever we are in our positions in universities and academic medical centers, whether we're researchers or caregivers or other members of the staff and faculty, we have to keep raising our voices through whatever mechanism we have. We have to call our representatives, we have to call our university leaders, we have to bring them into the conversation and explain to them the challenges, because I think it's complex. And when you think that there's not too much COVID in Africa, or you think that, well, we gave donated doses, we don't have the opportunity for change, we have to make extraordinary changes in our global systems here. We have to move into global solidarity and rights-based approaches to health and move away from the charity notion. It's clearly failing. And if we don't do something about it now, I think generations of people are going to look back on us and ask us, what on earth were we thinking? And what on earth were we doing? And how could we have made such poor choices for the future?
Thank you, Louise. And as you march outside, please relay our support to all your colleagues out there. And Emily, for your parting shots.
Yes, thanks so much for having me, and great to talk with you, Paul and Louise. And I think for me, the point here is to talk about this. When I somewhat recently polled a lot of friends, even public health colleagues, about this issue, actually people weren't very aware of this particular issue, which was really surprising to me, because it's, I feel, in my everyday, every moment life, but it's not out there. I think more so now with this new variant scare. So this may be an opportunity, but I think the second piece is that we have an opportunity here is to fight against some of these these tropes that, oh, there's no capacity to produce vaccines in low-income countries, that the vaccine isn't necessarily needed, or that there hasn't been cases, or that there's misinformation or poor health systems will prevent distribution of vaccines. I think we've been through this before, as Louise pointed out, in the HIV epidemic and others, where these false tropes about health in low-income countries, I think, also dampen political motivation to do something. So I think that's another place where we can advocate putting forward like the correct information about capacity and need. And I will look forward to, it sounds like many of our friends here in the audience probably have more experience in advocacy and politics, and really looking forward to collaborating with others who work on these issues more closely to understand how we can get the right information to the right people on time to make movement on this. So thanks, Paul, and thanks to everyone here.
Thanks, Emily. Keep the pressure going so that at some point we can then review and say at least we have achieved something in terms of improving on vaccine equity. So thanks to our two presenters, Emily and Louise, for taking your time to share with us your views on this very, very important topic. And thanks to all the participants for being here with us, and also for all those interesting and challenging questions. As we are now moving into the festive season, I would like to take this opportunity to wish all of you a restful festive season. The message is, let's continue to stay safe, and let's continue engaging in various efforts which are aimed at promoting vaccine equity globally. So we are going to share information on the next webinar. Hopefully it's going to be next year. So from all of us at the Bioethics Interest Group and at the Office of Research Excellence, it's a goodbye to all of you, and thank you.